Welcome to the lecture on the overview of critical care nursing. This one will discuss the chapters 1 through 4 and chapter 6. This is your introduction for critical care, complex care. So critical care, of course, deals with human responses to a critical illness or injury, which could be either or, physical or psychological. And the focus is on both the patient and the family's responses, not just the patient, because the patient's responses can be triggered or even calmed by the family's responses. The interdependence of a healthy work environment, clinical excellence, and optimal patient outcomes through AACN, the American Association of Critical Care Nurses, shows how a healthy work environment where you have true collaboration, effective decision-making, appropriate staffing, meaningful recognition, authentic leadership, and skilled communication all help encompass a true healthy work environment. It will significantly assist in reaching clinical excellence and optimal patient outcomes. The nurse is the patient's advocate. Your whole goal is to support their autonomous decision-making and then to support those decisions that they've made and to respect their values without any bias or judgment. You need to represent the patient's choices and represent the patient based on those choices. You are to intervene on the patient's best interests and intercede for those who are not able to do so for themselves, to help them get the care that they deserve and need. Your goal is to educate patients and family members, make sure that everybody's safe and they have quality care. You are the liaison between the patient, the family, and the other healthcare providers on the team. You are the person who makes this whole thing work. So here's a critical thinking challenge. What comes to your mind when you hear the following terms? Intensive care, critical care, ICU and CCU, trauma. Be prepared to discuss this in class. So the evolution of critical care. Well, the beginnings were when we had specific polio units. They created recovery rooms for surgery, and then they initiated coronary care units. And then it was noted that patient outcomes were significantly improved with this type of focused care. The photo that you see there is a young woman, or a young child actually, that is in a polio chamber for breathing. Well, we've come a long way, baby. Critical care in the 21st century is very specialized. We have practice in a variety of settings where you will have critical care in inpatient, outpatient, and even home care. This means that there are a variety of roles for nurses who work with critically ill patients to work in a lot of different environments, specialties, and areas of interest. There are some professional organizations that help support critical care nurses and their practice. For critical care, the key organizations are the American Association of Critical Care Nurses and the Society of Critical Care Medicine. I have the two links there for you to go to, but then of course there's other kinds of critical care, such as the recovery room, PACU. Well, they have the OR nurses and PACU nurses all have an organization related to the AORN, Association of OR Nurses. The ED has the emergency department nurse certification and their own organization. But specifically, as discussed in your book, in your text, we're talking about critical care for AACN and Society of Critical Care. AACN was originally founded in 1969, and it is now the largest specialty organization in the world. Their mission is to provide leadership which will establish work and patient care environments that are respectful, healing, and humane. And I have offered the website again for you. The little picture here of the hands around the center icon here is part of their image redo, and it's all about the holding everything you know and your patient in the palm of your hands. AACN's vision is to create a healthcare system which is driven by the patient's and the family's needs, in which the critical care nurse makes their optimum contributions. And it is a shift from where we are right now, and it goes back to looking at the patient's needs. The picture here is this year's theme for AACN, and it says, "Together, Stronger, Bolder." And that's what they're pushing for this year's theme, is that together we are much stronger and much bolder than we are alone. And again, you will see the two hands holding the center of the AACN membership benefits. Of course, you get professional journals, continuing education offerings, and they're free if you belong. The journals are the Critical Care Nurse, American Journal of Critical Care, and even the AACN Advanced Critical Care, and it's at a reduced rate for its memberships. You can also get practice alerts that are based on evidence. These are interventions that you can do based on evidence, and they alert you to changes in practice. This practice alert started many years ago, but one of the most significant ones that I recall when we first were going was that you're not supposed to irrigate an endotracheal tube with saline prior to suctioning, because really and truly all you're doing is drowning the patient and promoting bacterial installation and growth. So that's one of the very first practice alerts that was sent out by AACN. There's continuing education, and they are free to those who are members on their website. But the other thing is that there's something called the National Teaching Institute, or the NTI. This is an annual convention that they have, and they have it in a variety of different areas. They try to keep it back and forth between the East Coast and the West Coast. One year is the East, one year is the West, to allow as many people to go and get a rejuvenation as much as possible. It is very, very energizing to go to one of these and have the opportunity to be with people who are working on the same problems, same issues, and same aspects that you are. There's also local chapters related to AACN, and the national office supports those local chapters. There are scholarships that are available for nurses to return back to school, research grants. There is a student rate for those who want to be a member, so join and be a member before you graduate. And then there are discounted rates for those who want to go on and become certified in a specialty in critical care, and we'll talk about those certification exams in just a moment. Now let's compare that to the Society of Critical Care Medicine. This was founded in 1970, and it's a multidisciplinarian membership. AACN is all nursing. This one is multidisciplinarian. It has physicians, it has a nursing section, and then other critical care members are able to join as associate members. Their website is there as well, and they have their own journal as a member that you will be getting, and it's called Critical Care Medicine. The Society of Critical Care Medicine actually has on their website the history of critical care medicine. And it starts off talking about how it evolved from a historical recognition that the needs of patients with acute life-threatening illnesses or injuries could be better treated if they were grouped into a specific area of the hospital. Nurses have long recognized that very sick patients receive more attention if they are located near the nurse's station. One of the bullet points to talk about is how Florence Nightingale wrote about the advantages of establishing a separate area of the hospital for patients recovering from surgery. Intensive care began in the United States when Dr. Dandy opened a 3-bed unit for postoperative neurosurgical patients at Johns Hopkins in Baltimore. In 1927, the first hospital's premature born infant care center was established at the Sarah Morris Hospital in Chicago. During World War II, shock wards were established to resuscitate and care for soldiers who were injured in battle or undergoing surgery. They had a nursing shortage at that time, which followed the World War II episode. It forced the grouping of postoperative patients into recovery rooms to ensure attentive care. The obvious benefits are an improved patient care, resulting in the spread of recovery rooms to nearly every hospital by 1960. Between the years 1947 to 1948, we had the polio epidemic, which raged through Europe and the United States, resulting in a breakthrough in the treatment of patients dying from respiratory paralysis. In Denmark, manual ventilation was accomplished through a tube placed in the trachea of polio patients, hence ambu bagging, endotracheal intubation. Patients with a respiratory paralysis or suffering from acute circulatory failure required intensive nursing care. During the 50s, the development of mechanical ventilation led to the organization of respiratory intensive care units, or ICUs, in many of the European and American hospitals. The care and the monitoring of the mechanically ventilated patient proved to be more efficient when patients were grouped in a single location. General ICUs for very sick patients, including post-operative patients, were developed for this similar reasons. Johns Hopkins Bayview Medical Center became the first multidisciplinary and intensive care unit in the United States. It was created in 1958 at the Baltimore City Hospitals, now Johns Hopkins Bayview. The first multidisciplinary ICU in the country led the way for optimal medical and nursing care to critically ill patients 24 hours a day. It was also the very first ICU covered by an in-house physician, which they used an anesthesia resident 24/7. By the late 1960s, most United States hospitals had at least one ICU. In 1970, 28 physicians with a major interest in the care of critically ill patients who were critically ill and injured, they all met in Los Angeles, California to discuss the formation of an organization committed to these needs, and this is when the Society of Critical Care Medicine was established. In 1986, the American Board of Medical Specialties approved a certification of special competence in critical care for 4 primary boards: anesthesiology, internal medicine, pediatrics, and surgery. Between 1990 and the present, critical care significantly reduced in-hospital time as well as costs incurred by patients with diseases such as cerebrovascular insufficiency and respiratory failure. There was the development of new and complicated surgical procedures such as liver, lung, heart, small intestine, pancreatic transplantation, which created a new and important role for critical care after transplantation. There's widespread utilization of non-invasive patient monitoring, which further reduced the cost of medical nursing implications such as infection associated with the care of the critically ill and injured patients. Widespread utilization of pharmacological therapy for critical care patients became significant when treating the specific organ system failure. They reduced the time spent in both critical cares and the hospital overall. By 1997, there were more than 5,000 ICUs operational in intensive care units across the United States. The Society of Critical Care Medicine's vision is that they want a healthcare system in which all critically ill and injured persons receive care. They want it to be a multi-professional healthcare team directed by a physician specializing in critical care called an intensivist. So now we're going to bounce back a little bit to the critical care nursing and AACN and tell you a little bit about critical care certification for nurses. The purpose is to validate the knowledge that the nurse has, promote a professional excellence, help nurses maintain up-to-date knowledge based on evidence. There is an AACN certification corporation which oversees the critical care certification process. It is based on AACN's synergy model for patient care, where the needs of patients and families drive the overall practice. For bedside practice, there's a CCRN. You can get it at specialty in adult, neonatal, and pediatric, which that's the one that I've had, and I've had it for over 20 years. It is a critical care RN. The PCCN is for those who work in a step-down unit. The next layer is advanced practice. CCNS is a critical care clinical nurse specialist, and you can do a certification specific for that. And then there's the acute care nurse practitioners certification. If you have a CCRN or a CCNS, or even a PCCN, you can get a subspecialty certification in either cardiac medicine or cardiac surgery, depending on what your practice is. The standards for the certification is that standards actually guide clinical practice. They establish goals for patient care, provides assessments of outcomes, and AACN has standards for acute and critical care nursing practice. Sorry, not certification, but for actual nursing practice. It describes the level of performance. It also describes the expected roles and responsibilities of critical care nurses. So let's talk about some of the standards of practice. So some of the standards are to evaluate nursing practice, reflect on standards, laws, and regulations, acquire knowledge, interact and contribute to peers, serve as a patient advocate, collaborate with healthcare team members, use clinical inquiry, and consider factors related to safety, cost, and effectiveness. So now let's talk about trends and issues. Well, critical care patients are more complex than ever before. Lots and lots of patients are older population, which complicates things. And then, of course, we have a lot of patients who are going into multi-system organ dysfunctions and organ failures. These are really, really complicating things, especially when patients have, quote, severe comorbidities. There's a rising cost of care. Nurses are being challenged constantly to reduce the costs and the lengths of stay. Patients are being transferred to higher acuity levels from critical care units to other units or even home. So if they're still critical care patients, but they're being bumped down to a progressive care or even a telemetry unit, and then even going home much sooner than they ever did before. I like to share that when I first started in ICU, the patients that you see on telemetry are actually the patients we used to see on Med-Surg. Sorry, reverse that. Med-Surg are the patients that used to be at home. The patients that are on telemetry on Med-Surg used to be on telemetry, and the patients on telemetry are the patients we used to take care of in ICU. The patients in ICU now, we didn't get them before. They didn't survive long enough. So it's really been a huge impact having critical care and all of the technology and the evidence that's come around in the last, well, now I can say it's been over 50 years. We are constantly being requested to focus on quality and safety. One of the governing bodies is the Joint Commission, and they have the National Patient Safety Goals. There is in your book a box in Chapter 1-4 gives you some examples related to critical care nursing. Safety goals related to communication, medication safety, reducing infections, preventing pressure ulcers, and family involvement in care. You can go to www.ahrq.org, and that will give you a link to the National Patient Safety Goals. If you do the PDF easy to read format, you'll be able to see what the current National Patient Safety Goals are for this year. This is the link that you can click on. You can also go through jointcommission.org, or you can go through AHRQ, as I described on the last slide. This link takes you directly to Joint Commission's easy-to-read form, and it is a PDF, and it shares with you what the patient safety goals are for the year. So, of course, communication is high on that list because it's important that we effectively communicate to help reduce errors. I will say that the SBAR format was something that's really been pushed over the last 5 or 6 years, and it has really been successful in helping cut down on medication errors and treatment errors that are confused during miscommunication. It is an SBAR format. SBAR stands for Situation, Background, Assessment, and Recommendation. Other safety initiatives that have come through the Joint Commission and pushed for patient safety. The Rapid Response Team, that was actually initiated about 6 years ago for a Rapid Response Team. You want to get patients taken care of before they code, and that's what the Rapid Response Team is supposed to help us do. Take care of a patient issue prior to them getting critical enough that they are getting ready to code. There's also the Institute of Health and Care Improvement that also has pushes on safety initiatives, and then of course we have clinical practice guidelines, which is on guideline.gov, that gives you the standards of practicing guidelines for you to help take care of your patients and standardize the care that they get. One of the ways that they have used some changes to help facilitate collaboration with the multidisciplinary team is to have multidisciplinary team rounds on a daily basis. And you have some information on Chapter 1, Box 6 that shares some of the different things that you want to talk about on those daily rounds with the multidisciplinary team. The other way that we are helping with transit issues is the implementation of bundles to care for patients, but it's still helping to promote evidence-based practices and prevent complications. One of those that you may already have heard about is VAP, ventilator-associated pneumonia. There is a ventilator bundle. You're supposed to keep the patient's head of bed elevated at 30 degrees. You're supposed to do oral care a minimum of every 2 hours. You're supposed to suction patients a minimum of every 2 hours and as needed. You're not supposed to instill saline prior to suctioning. And there's some specific ways to do the oral care to help promote decreasing secretions that are sitting on top of the endotracheal tube cup. And we'll talk about some more of that. But that's just one example. Another bundle would be the SCIP bundle, where they're preventing surgical infections. Technology has actually brought us a long way. We now have the ability to have advanced monitoring devices. When I first started in nursing, we did not have ART lines or Swan catheters. Or, as a matter of fact, I helped Dr. Swans and Gans do their first studies on the first pulmonary artery catheter, which we called a Swan-Ganz catheter for a very long time. You may take for granted this Accu-Checks done at bedside, but we didn't have any of that, and it had to be a lab, and it had to be done by a lab technician. Nurses were not allowed to do that. We are progressing. There's actually a requirement that hospitals have to have computerized physician order entry, and all hospitals have to have computerized documentation by a certain time frame. And so we are moving along. And telemedicine has brought us a long way. There's electronic ICUs, there's telemedicine where they actually can telecommunicate with patients and their monitors and their defibrillators from their home over the telephone. Also, there has been some significant improvements in the design of critical care units, and then one of those would be like the Beacon Award that AACN has in helping to promote the appropriate design and environment for critical care patients. There is a shortage of critical care nurses, and they are working significantly on making sure that nurses are recruited, oriented appropriately so that we can actually do better retention for nurses in critical care. There's an ongoing debate about hiring new grads to work in critical cares, but I have to tell you that I worked in critical care as an LPN and was hired into the same ICU unit as a new grad RN, but I was in there as an LPN prior. And that's pretty much what got me going back to get my RN, was because I was going to be kicked out of ICU and had to go back to med-surg, and I didn't want to go. I will tell you that as a new grad, I didn't have any bad habits to unlearn when I got into critical care, so it was pretty significant. Now, the last hospital that I worked at, and I was a manager and educated there originally, was at West Valley Hospital, and they do and have in the past, as well as some of the other Abrazos, hired new graduates for the intensive care unit. I will tell you that there are a few others out there. I don't know all of them, but there are some that do not hire new grads for any critical care areas. So that would be something that you would have to ask your nurse recruiter and the manager that you're interviewing with on what the possibilities are. A lot of times there's an ability to transfer 6 months after hire, especially if you show a keen sense of critical thinking. So let's talk about the critical care experience in the patient's view. Critically ill patients are at a high risk for actual or potential life-threatening problems. Critically ill patients are cared for in a variety of settings, not just in a critical care unit. We're talking about PACU, we're talking about ED, we're talking about a specific ICU like neuro ICU, cardiovascular ICU, or a general ICU, a trauma ICU. So it has become very specialized. So as a critical thinking challenge, think about a critical care environment if you've ever been there. So how would you describe an ICU? What might be some of the sights, sounds, and smells that you would experience? What sensations might you experience? And how would your family react to the situation if you yourself were in the ICU as a patient? And I want you to be prepared to discuss that in class. So this is your critical thinking challenge that we will talk about in class. Well, needless to say, the critical care environment is filled with all kinds of stressors, such as loss of privacy, artificial lighting too, noise, lots and lots of noise, a lack of meaningful stimulation. There's lots of stimulation going on, but, you know, is it somebody holding your hand meaningfully? Or is it just you only talk to your patients to ask them a question? Are you having a meaningful conversation? Lots of pain. One of the biggest things is patients complain about the loss of autonomy as well, that's a huge impact on them. One of the things that we need to do to modify the critical care environment, which has actually been pushed as far as one of the safety things, because sleep deprivation really causes a lot more problems than it solves. One of the biggest things is noise reduction. They have actually changed all the tiles in the ceilings so that they are acoustic tiles. They have started designing ICUs to help block noise rather than allowing the noise to carry down hallways and echo like some of the hospitals you might hear. Some of them even provide soothing music for patients to listen to and families. There are private areas for communication between the caregivers and the family members rather than a great big waiting room or in the patient's room. Appropriate lighting, adequate lighting, using natural lighting such as windows in all of the patient's rooms. Day-night synchronization. So if your patient is a night person and you leave the lights on all night long, do they know it's night? Absolutely not. So turn the lights out, turn the TV off. It's nighttime. They don't know that unless you help them understand that. A lot of the units are being designed to help promote health and safety now, rather than just being functional as hallways and rooms and nurses' stations. There are many factors that influence a nurse's ability to provide care to their patients. One would be the nurse-physician interaction. Another would be the type of clinical area you're in, or even the culture of the organization or the culture of the unit itself. What I mean by that is, what's the tempo, what's the mood, what's the climate, how is the unit designed? Are we family friendly or family resistant in this particular unit? So healthy work environments help promote safe, healing, and humane work settings. The components that you want to look for a healthy work environment would be skilled communication, true collaboration, effective decision making, appropriate staffing, meaningful recognition, and authentic leadership. Which, remember the circle that we had, those are the things that were in the healthy work environment, or HWE environment symbol that we had earlier. So communication is essential for safe patient care. Handoff situations provide the greatest risk for communication breakdown. And so what other strategies do you think can be used to enhance communication? We've talked about one. So what was that strategy, and what might be some of the other strategies? So this will be one of the critical thinking challenges that we discuss in class. So the first one, of course, we talked about SBAR, Situation, Background, Assessment, and Recommendation. There's another one called a Crew Resource Management. We call that a CUS, where the person says, I'm concerned, I'm uncomfortable, this isn't safe. So you're raising your concerns. That's called a Crew Resource Management or a CUS strategy. Collaboration. Well, teamwork is kind of significant. It helps create a culture of safety. It helps recognize all the unique contributions of all the team members. So if you use interdisciplinary rounds, respiratory, dietary, pharmacy, the nurses, and the doctors are all right there, and they can talk about the case and the situation, and everybody is on the same sheet of music. They're all on the same track, and they all know what the plan is. Typically, they do it first thing in the morning, and it's called a morning briefing, so that things can be planned for the day, and then they can do another one later and see how that plan has worked. So they need to evaluate it. So we're planning, we're implementing, and evaluating. So patients respond variously to critical illnesses. And their responses vary according to age, whether they've had prior illnesses or prior hospitalization experiences or not. Do they have a family relationship and social support system? Do they have appropriate coping mechanisms? What are their thoughts and beliefs about life, death? Are they spiritual? And what are their the cultural considerations that you might want to think about? With so many cultures living in America is very significant. There was a study done, and there was a survey of patients who were transferred out of the critical care onto a regular unit. And they do it fairly quickly because they tend to forget information. The longer they're out of critical care, they tend to forget their experiences there. That's just kind of how the body's mind works to help protect you. But some of the things that they do recall immediately after transfer is that they had a lot of difficulty communicating. There was pain, there was thirst, problems swallowing, anxiety, a lack of control, depression, fear. They were feeling separated from their family, and they were not real happy with that. Lots of feelings of dread, discomfort, difficulties in sleeping, loneliness, thoughts of dying, and then they remember being physically restrained as well. So we have to provide psychosocial support for our patients. We have to assure them of their safety. We have to do things to reduce sleep deprivation. We have to reduce noxious sensory overload, which is the noise. We need to create as pleasant a sensory input as possible. And then we need to also provide reorientation for the patient. So what are some of the strategies that you can do to help achieve these goals? So we're going to discuss this in class. Be prepared to answer this question. Some ways for you to react. Critical care patients need to feel safe. They need to feel like they're safe, and they need to understand that. So some of the nursing interventions that you can do is to be very technical, competent. If you're working with some of the equipment, make sure you know what you're doing. If not, patients can sense that if you start fumbling with things, and it makes them more anxious. Vigilant response. Do not delay responding to a patient that's in critical care. One of the biggest things that I had patients tell me about was their concerns about the alarms going off, because they watched on all of the medical shows that when the alarms went off, they were dead and they were having to have rescue. And so every time the alarms would go off in critical care, patients were just literally freaking out. And so I started talking to all my patients going, you know, you may hear alarms, but they're not that you're dead or that you're having problems. I have set the alarms so that they will go off early enough that I can do something or it's an alarm to remind me of something. And actually that made a significant difference in patients that I was caring for. Allowing the family to stay at bedside or to be there as often as possible actually helps alleviate the loneliness and the fear that patients have, in addition to relieving some of the fear and anxiety that the family has in that separation. They have no idea what you're doing to their family member while they are not there, so they're a little bit anxious as well. It helps if you provide information, and then make sure that your patient is oriented and reoriented as necessary. So after the patient has been in critical care and they get moved out to the floor, what's their quality of life after critical care? Well, there have been some post-critical care symptoms, and those are fatigue, sleep disturbance, pain, muscle weakness, poor concentration, impaired memory, poor appetite. They have post-traumatic stress disorder-like symptomatology, and even PTSD itself can develop in either the patients or the family, depending on the situation. Patients being discharged from critical care, it can be very difficult on the patients and the family. They're very concerned. They're worried that, well, they're not going to get as an intensive care as they were getting, you know, where they are now. What if something happens? What's going to be the problem? They're relocated, and they have relocation stress, so they have fear of being abandoned by the nurses that they're accustomed to. They have to learn new people, new routines, maybe even have a new roommate or a roommate where they didn't have one. So some of these things can be very stressful on them. So be sure to prepare patients and family members what to expect upon transfer to another unit from the critical care area. So let's look at some geriatric concerns. Geriatric patients have a diminished ability to adapt or cope to stressors when they have a critical illness, and they have a higher risk for negative outcomes. They don't bounce back like they used to. Family members, please understand that critical illnesses or critical injuries affects the entire family. There's emotional distress. They're very concerned about finances. It can even lead to financial bankruptcy. What might be some of the other things that family members might be concerned about and that kind of thing? And know that this can then influence the patient and the patient's recovery. There is a tool called the Calgary Family Assessment, which it will help you understand a little bit more about the family environment. So you're going to look at the structure of the family. What's the internal structure? What's the external structure? And what is the family context? I mean, is this the black sheep of the family? Is this the angel of the family, the most favorite? So you're going to have 40 million people in there. If it's the black sheep, you're going to have a hard time getting anybody in there. Those are the different kind of things that you need to think about when you have patients in the ICU. There are developmental stages that have to be addressed. What are the different stages? What are the different tasks that have to be done in different stages? Because you're going to get all kinds of ages of people in ICU. You may have a 20-year-old. You may have a 30, 40, 50-year-old. So what are the different stages of development, task orientation, and then their attachments? Functionality. How do they interact with each other? Who is the key instrumental person? And how do they express themselves, and are they expressive or are they reserved? Families need to receive assurance. They need to be able to stay as clear and as near to the patient as much as possible. They need to have appropriate, accurate information. They need to be comforted, and they need to have support available. So a lot of times they don't recognize that they can't be the one that's sitting here day in and day out, day and night, 24/7, because their body's going to deteriorate. So a lot of times they have to have their very own support system, because not one person can do this alone. It takes a village. So some different family interventions that you can do is you can facilitate their visitation, provide information, encourage family involvement in the activities of patient care, and then sometimes even considering family presence during procedures, like during rapid responses and during codes. So family presence during those emergency situations has actually shown that patients and families are less disturbed and they are more realistically in tune with what's going on if they are allowed to remain present. So here's another critical thinking challenge. These are questions I want you to think about and then be prepared to answer in class on Wednesday. Critical thinking challenge. Who should visit the patient? How are you going to facilitate the visitation? What factors support family presence during procedures and resuscitation? How do you feel about that? How about open visitation versus limited visitation? What do you think about that? Some other things I want you to think about and be able to talk about and discuss is, why do you think a nurse would choose to work in critical care? What might be some of the driving forces within themselves? What are some of the issues related to recruitment and retention of critical care nurses? Is it hard? Do they get burned out? And is it hard to recruit nurses? And do they not last as long as you wanted? So we'll be able to discuss that in more detail in class. Okay, so we talked about the synergy model for patient care by AACN a little earlier in this presentation, so let's go back to that. It was developed by the American Association of Critical Care Nurses to help guide practice. The needs of the patient and the family are the ones that drive the competencies of the nurse, and we need to match the needs of the patient with the nurse's competency levels. And we need to work together to create that synergy model, that synergistic attitude and behaviors, and it promote positive outcomes. So let's talk about some of the nurse competencies in the synergy model. Clinical judgment, advocacy and moral agency, caring practices, collaboration, systems thinking. What is their response to diversity? Do they facilitate learning? And do they have clinical inquiry as part of their competencies? Patient characteristics within this model are that patients are resilient, even though they're vulnerable. What is their stability? Patients are complex. Do they have resources available? Can they or their resources participate in their care? We need participation in decision making. And what is the patient's predictability? Okay, so now we're going to move to the next chapter, and we're going to talk about ethical and legal issues in critical care nursing. So critical care nurses confront ethical issues every day in practice. They have to talk about informed consents, confidentiality, withholding or withdrawal of treatments, organ and tissue transplantation and donation, distribution of healthcare resources, who's going to get what, impacts of advanced technology, and the greater frequency of all of this happening in the critical care over a general care area. Nurse advocacy. Nurses are obligated to protect patients and serve as the patient's advocate. Professional organizations promote both ethics and advocacy, and that's the American Nurses Association has a code of ethics for nurses with interpretive statements, and also the American Association of Critical Care Nurses has an ethic of care statement. When you are thinking about or seeing or approaching an ethical dilemma, there are warning signs. Emotions will become very charged. There'll be a significant change in the patient's condition. There will be confusion about facts. There'll be concerns about hesitancy. What is right? Are you sure about this? Sometimes there's even deviation from what is standard or customary practice. And then, is there a need for secrecy regarding the proposed actions? These are all warning signs that you may be approaching an ethical dilemma situation. So in your book, Chapter 3, this is the very first diagram, and this is actually an ethical decision tree to help you go through the process of making ethical decisions appropriately. So the ethical decision process, or the ethical decision tree, the first thing is you want to assess, right? So we want to assess things. So what are the different factors, contextual, physical, and personal factors that are involved? Then you want to consider the different options, and those options are, what are the patient's wishes? What is the burden versus the benefit? Are there any ethical principles to be evaluated or considered? And what's the potential outcomes based on what you decide? The next step would be then to develop a plan with the patient, the surrogate family, and the entire team. Then you're going to act on that plan and then evaluate that plan, looking at both short-term and long-term outcomes, and then maybe do a comparison to how this applied to other cases in the past, or how will this apply to other cases in the future. So looking at ethical principles, there's the principle of autonomy, where the patient has right of self-determination concerning their medical care. There's the ethical principle of beneficence. This is where there's a duty to prevent harm, remove harm, and promote good of another person. The last one is non-maleficence, where you are not to intentionally inflict harm. Some other principles to be considered is justice. That means there is a fair distribution of healthcare resources, equal fairness. Veracity. What's the truth? How much is the truth and how much is being fudged? Truthfulness, veracity is extremely important when you are talking about ethical issues. Fidelity. Once you make that commitment, be faithful to that commitment. And then confidentiality, respect for the right of control of information. Patients have the right to confidentiality no matter what their decisions are. So let's talk about some moral theories. Deontology is ethical decisions being made according to principles. Utilitarianism is where ethical decisions are made considering the greatest good. And then causatory is ethical decisions made by examining similar causes. So taking all of that into consideration, what is the nurse's involvement in ethical decision making? Advocacy, we've mentioned that already. Make sure you have open communication of the patient's wishes and their ethical concerns, and be a true collaborator with the healthcare team members about being that patient's advocate and what their wishes and ethical concerns are. Dilemmas can result in moral distress, not just your patient's, but even yours. Formal mechanisms. The Joint Commission actually recommends bioethics committees and ethics consultations with ethicists. And a lot of hospitals do have those bioethics committees, and they do have an ethicist that generally sits on that committee. There are opportunities for critical care nurses to learn by participating in ethic forums, ethic rounds. Peer review is very beneficial. And then institutional review boards. You may want to research more about that, especially if you're interested in the review boards of the medical staff or the nursing staff. Our state board, Arizona State Board, has a review board that looks at ethics and ethical dilemmas and nurse involvement. So let's talk about legal accountability. There are legal responsibilities that nurses have to patients. They are the benchmarks for defining what the nurse's responsibilities are. The nurse is to prevent situations that will compromise the patients. It's much more preferred than attending a court hearing. So preventing a situation is much better than responding to a court case. Licensure. Of course, nurses must be aware of whatever the state licensure requirements and regulations are, what the scope of practice is for that particular state, and are there any required continuing educations. Currently, Arizona does not have any required continuing education for their RN license renewal. However, some of the hospitals are doing that on their own, and it is being discussed at the state board level of possibly requiring mandated continuing education units for a certain amount for every 2 years of renewal. Hospital requirements may vary. Some of those continuing education things you have to show skills every year to ensure your competency, and they may mandate that you go and get some type of certification showing that you have been certified and are able and competent to perform your duties. Criminal lawsuits. These are defined by state law. So battery is where you are touching a patient against their will. Assault is where you threaten to batter a patient. Assault is the threat. Battery is the actual performance. False imprisonment. This is where you are preventing the patient from leaving the hospital, leaving the room, leaving the bed. So that is something you have to consider. You want to prevent. Prevention, very, very important. Be very consistent in your job performance. Promote satisfaction of both the patients and the family members, and stay within your scope of practice and follow the hospital's policies and procedures. Do not violate those. Medical malpractice. Are you negligent or are you incompetent? Well, it's defined by, did the nurse have a duty to the patient and they did not carry out that duty? Or did they cause injury and did the patient suffer because of that injury? That's the differences between negligence and incompetence. So what are some of the medical malpractice cases that you might have heard about for nurses? So how do you go about preventing malpractice? Act according to the standards of practice, standards of care, wherever you are practicing, and make sure you are documenting. Document. I'm sure you've heard it, but I just don't think you can hear it enough. Documentation is significant. Plays huge role. You may take care of about 50, 60 patients in just a few weeks, and then a lawsuit comes up, and are you going to truly remember everything about that patient's care? Well, you need to be able to read your notes and your information to refresh your memory enough to recall that patient and what occurred. So make sure that your documentation is very clear and as thorough as you can get it without going overboard. So now let's talk about what there is to a duty to treat. Nurses are required to care for their assigned patients. It's considered a contractual relationship. Abandonment is where you as a professional, you sever that relationship despite the patient still being in need of care. You must ensure the patient care is arranged with another nurse, which includes your breaks and your lunches. Do not even go to the bathroom without making sure that your patient is being covered while you are away from their away from the unit for even going to the bathroom. Otherwise, if something happens, you can be charged with abandonment. Moral conflict. Nurses are not required to practice if the situation violates a moral or a religious belief. Patient care must be transferred to another person to avoid abandonment before you leave that patient's care. How should the nurse approach a situation that results in moral conflict? So I want to talk about that in class. What do you think the process would be if you had a moral conflict and could not care for a patient? How would you go about getting that coverage that you needed to get? And would that mean that you were just changing your assignments, or do you think you would have to leave the entire hospital for the day? I mean, so those are some of the things we want to talk about. So now the next step is to talk about some selected issues. So the first one is informed consent. Competence. Is the patient competent? Do they have an ability to understand what you're saying? Voluntariness. They are consenting to this procedure or whatever it is without being coerced. And then, of course, there's disclosure of information. That includes diagnosis, proposed treatment, probable outcomes, what's the benefits, what's the risks, what are the alternative treatments, and what is the prognosis if they refuse to take that treatment or it's not provided. And what is the nurse's role in this informed consent piece? So let's talk about that in class. So informed consents of adolescents. Parents and guardians are required to be the person to give consent. Emancipated minors, however, can give their own consent. So they have actually become legally adult in the eyes of the court of the law by a court case that they brought forward, and so emancipated minors can give their own consent. Otherwise, a parent or guardian is required to give consent for anyone under the age of 18. Okay, let's talk about some life-sustaining treatment. Things to think about is constitutional rights of the patient. What's their quality of life going to be after the fact? What is the impact of advanced technology? Is it beneficial? Is it beneficial all the time, or sometimes is it detrimental? What is ordinary care versus extraordinary care? These are some of the things that you need to think about. So let's talk about one of those extraordinary things, CPR. CPR issues, remember, should a patient be coded? A do not resuscitate or DNR order is needed in order to not initiate a code or initiate CPR. The advanced directives are useful in guiding decision making prior to a code situation. My question to you is, when does a resuscitation effort stop? How about if you are out in public? How about if you are in a hospital? When does the resuscitation effort stop? You hear a lot about life support. Life support. Well, life support, withholding or not initiating a form of life support, such as feedings, water, breathing tubes. Withdrawal means they already have that life support, and we are either removing it or weaning them. Comfort measures are maintained no matter what you're doing, and there are debated views on withholding and withdrawal of life support. Nurses play a significant role in helping families make decisions about life support and the heroics of CPR and codes. Make sure that there is frequent communication going back and forth. It needs to be consistent and honest communication. It needs to be based on what's the patient's wishes, and it needs to provide, the nurse needs to help provide psychological support to the family once that decision is made. The United States has a Patient Self-Determination Act. This is where the patient has the right to initiate their advanced directives, and they have the right to consent to or even refuse treatment. So in Chapter 3, Box 5, it's talking about advanced directives. This is a communication about what the patient's preferences for their treatment is if they become incapacitated. A living will is the treatment that is desired and what shouldn't be withheld. So it's a little bit of both. A durable power of attorney for health care is a binding contract determining who the patient has chosen to make their decisions if they are no longer able to do so. Sometimes, if that's not significant, or there's been a challenge, or the person who has durable power of attorney is no longer capable to make decisions because of Alzheimer's or something else, sometimes a court of law will designate a healthcare surrogate or proxy to take on that durable power of attorney. So now let's talk about organ and tissue transplantation. Patients who are considered brain dead are often candidates for organ donation. You need to know what brain death criteria is. Everyone has the right to donate organs or to refuse. Sometimes there's even a conflict of what the patient's designation is versus what the family members' views on donation are. So if the patient says yes, donate, and they've signed donation cards, and then the family says no, we're in a little bit of a dilemma. There are designated requesters that have had special training, and only designated requesters are to approach family members to seek consent for organ and tissue transplantation. So another critical thinking challenge: what are some examples of situations where a nurse might have a moral or a religious conviction that would interfere with their duty to treat a patient? And what are those actions that the nurse might need to do when that conflict exists? Then I want to have an open discussion about how many of you have a living will? How many of you have a durable power of attorney for health care? Do your family members know what your wishes are? So, and then we'll kind of talk about different strategies that can be implemented to get more people to complete their own advance directives, because you never know when something will happen and it will be needed and you did not get it done. So some other things we want to talk about are, what are the issues related to organ donation? What are some strategies to help increase donation, especially among the ethnic minority populations, because they are very, very small numbers in donating organ transplant, and skin and tissues. Have you signed an organ donor card? And can your family members overrule your wishes if you have? I'd like to discuss that as well. So now let's talk about end-of-life care in the critical care unit. There have been a lot of advances in technology. It's helped us be more able to care for patients who are critically ill. Sometimes it can even be used inappropriately on people who have a very poor prognosis, and we do everything we possibly can, and it will not benefit them, and it will not change the prognosis at all. Some of those advances are very invasive, very costly. Sometimes, if they're used in a potentially futile situation, it becomes very controversial, very heated between nurses and doctors, and whether this was the right thing to do or not. And sometimes ethics committee has to be called in to help de-escalate some of the issues and to come to a consensus on what the final decision should be. There is a study called SUPPORT. It was a landmark research, and the study was to understand the prognosis and preferences for outcomes and risks of patients. The study was done in 1995, so by our standards, this is old information. It's over 5 years old. There's disparity between the patient preference and the care that was provided. There was shown a lack of clear communication between the patients and the healthcare providers. Aggressive care was frequently implemented despite the patients not wanting it. Patients experienced pain and suffering because of this implementation. Research on the care of dying patients in critical care is lacking, and it needs to be nationally prioritized and addressed. And I can tell you, in 1995, that was the last study. It's still old, and no real significant information has come since, which is kind of sad. That we're doing things against patients' wills, and we're actually making things worse instead of better sometimes. So let's talk about some factors that are related to having aggressive care at the end of life. Failure to discuss death and dying by patients, families, and the healthcare team members can lead to aggressive care that really the patient doesn't want. A lack of assessment tools to help provide early identification of patients who are at the end of their life. And then identification in end-of-life patients is very subjective sometimes, not always objective. Okay, let's talk about the societal values of death and dying. Disease is distinct and curable. The purpose of the healthcare system is to preserve life. Death is a failure on the part of the system or the providers. Now that's kind of how society and physicians look at this. Nurses don't quite look at it this way, and society didn't used to. It was actually pushed through the medical field because they're all into curative. That is their goal, is curative. And so now society now values this same kind of ideology. Medical futility is a clinical situation where life-sustaining therapies or interventions will not provide foreseeable possibility of improvement in a patient's health condition. This diagram is in your book in Chapter 4, and it's the guidelines for pharmacological interventions during the withdrawal of life support. So here is our critical thinking challenge. We've got a patient who is a 76-year-old man, end-stage COPD, living well, requested that respiratory support and supplemental nutrition support be withheld. His son, who has not seen him for years, meets with the doctors and requests that a tube feeding be initiated because his father appears to be starving. So what might be the concepts of medical futility within this case? What communication issues affect the end-of-life decision-making in this situation? What are potential legal and ethical issues addressed by this case? Some ethical and legal concerns when you're talking about end-of-life. Poor communication can result in a conflict. Healthcare team members, patients and families, and within families themselves. So all of these people can be conflicted especially if there's poor communication. Surrogate decision making. This is where there's a healthcare surrogate designated by the patient as part of an advance directive, and they are to act on decisions for the patient in the same similar situation as the patient would have chosen. A proxy is a legally designated decision maker. The state statute may designate an order of succession, which we do have that here. With advance directives, they will describe a patient's preference for the treatment in terminal or vegetative states. They are legally recognized. The presence of an advance directive and an end-of-life care desire should be shared with significant others well before it's needed in the hospital. I'm not sure how many of you may remember the Florida case of Mrs. Shivo. This was the case that was in Florida. It addressed the withdrawal of enteral nutrition in a woman who was persistently vegetative with no living will. She was very young when she had a stroke, I believe it was. The case was potentially avoidable if an advance directive and effective communication in the family had taken place or been in place. Their lack of advance directives common with many critically ill patient issues, and so it does cause issues. If you're not familiar with the Shivo case, we can talk about it a little bit more in class. Some of the issues related to that case: self-determination in the absence of the living will. She didn't have a living will. She was not able to speak. She was vegetative. So the only other person was her husband. The family, her mom and dad, wanted them to continue indefinitely, which she had been on tube feeds and all that kind of stuff for like many, many years. The husband finally, after years and years and years, determined that it was time to let her go, and he was actually ready to move on, get married again, and the mother and the father of the woman was they took it as if he was just ready to kill her and get on with it because he was ready to move on with his life. So there was a lot of issues, a lot of anger, a lot of emotions involved. Legal authority of the surrogate decision maker was challenged, which is the husband, and it was challenged by the mom and dad of the patient. Ethical challenges are faced when advance directives is not executed and the surrogate decision maker is identified, but yet the information is disputed. So what are some of the ethical and legal concerns, and what are those effects on nurses and the overall healthcare team? Burnout. If you are providing painful treatments to patients in potentially futile situations, it will take an emotional toll on you, and you will become very frustrated and sometimes even emotionally detached. If the care conflicts between patients, surrogates, and the clinicians, if there's a lot of discussion and argument about what kind of care is to be provided and why. And then, of course, sometimes we have to worry about maintaining the patient's dignity when it's in an unfavorable environment. Sometimes patients come in and they have been abused by their children or by their parents, who only want the Social Security and that kind of thing, and do not actually want to care for the person that they need to be caring for. So there's a lot of things that have to be concerned and thought about. Some other things, failure of physicians to convey futile prognosis to patients and family members can cause conflicts. Issues with informed consent. Did we get informed consent or not? Is it being disputed? Grief experienced owing to the loss of the patient sometimes can cause conflicts. And then maintaining a balance between professionalism and humanism. Maintaining a compassionate involvement, but yet maintaining your professional distance can be very complicated and hard to do. So I want to talk about some of the different types of end-of-life ethical issues that may confront a critical care nurse, and then what might be some of the interventions that nurses can use to maintain their own emotional health when they are working with end-of-life patients. So the dimensions of end-of-life care, we're talking about palliation, communication and conflict resolution, withdrawal, limiting, or withholding therapy, emotional care to the patient and the family, and then, of course, support. With palliation, there's relief of symptoms of the injury that negatively affect the quality of life of the patient and or the family. They are not limited to dying, and there's a focus on the symptoms of relief. So what might be some examples of distressing symptoms in the dying that can be amenable to palliative care interventions? What interventions can a nurse and other healthcare team members implement to promote relief of distressing symptoms? So let's talk about some of those. With palliation, some common distressing symptoms would be like pain, anxiety, hunger, thirst, dyspnea, bowel alterations like diarrhea and constipation, nausea, agitation, confusion, and of course sleep deprivation or altered sleep patterns. So the elements of palliative care could be relief of those distressing symptoms, basic nursing interventions such as frequent repositioning, providing hygiene care, providing restful environment, and the whole palliative care team is used, and ideas are all used in contribution. One of the things you want to do is have early identification of end-of-life patients. Make sure that pain is managed as that fifth vital sign. There's pharmacological and non-pharmacological interventions to help relieve their pain, control their anxiety, and control any other distressing symptoms they may have. So now let's talk about withholding, limiting, or withdrawing. It is not euthanasia or assisted suicide. It's not considered pulling the plug or starving a patient. It is a shared decision-making model. The withdrawal of treatment or the discontinuation of life-sustaining therapies in a terminally ill or persistently vegetative patient, that decision is made by more than just one person. The withholding of treatment or the failure to initiate life-sustaining therapies in a terminally ill or persistent vegetative patient is where you withhold that treatment. Generally it's done because it's also done as a decision made by more than just one person. The whole team participates. Some of those therapies that can be withheld or withdrawn would be like respiratory support, ventilators, endotracheal tubes, vasopressors to make their blood pressure go where you want it, Dialysis, if they have end of life related to their kidneys and they don't want to do dialysis because it's not really going to help, it's just going to postpone their death by just a few days, that could be one of those treatments. Nutrition support, hydration, antibiotics and other kind of medications, and a lot of times blood administration may be refused or limited. Some of the ethical principles to review and know about when you're talking about withholding, limiting, and withdrawing treatments is that death is a product of the underlying disease, and the goal is to relieve suffering, not to hasten the death. Withholding life-sustaining treatment is a moral equivalent of withdrawing treatment, and any treatment with patient and family consent can be withheld or withdrawn, again, with that consent. Any dose of an analgesic or an anxiolytic can be reasonably used to control pain and relieve suffering. Life-sustaining treatment should not be withdrawn from patients on paralytic agents because that will hasten death. Cultural and religious perspectives may affect patient and family decision making, so discussion, communication is very important. So your nursing interventions are to provide anticipatory guidance to patients and families, anticipate any distressing symptoms and medicate to help relieve those symptoms, titrate the therapy to relieve their emotional and physical distress. Those are your goals. Some of the other things that you will need to do is to have continuing ongoing assessments of whatever their response is to the therapy and their comfort. You'll need to have pharmacological and non-pharmacological symptom management like benzodiazepams for anxiety, morphine for dyspnea and pain. There is a medication titration to relieve symptoms, and it's usually a protocol, and if you'll look at chapter 4, the first diagram, you'll see a protocol there. Terminal weaning. AAC and clinical practice guidelines says that this can include titration of a ventilator to minimal levels, removal of a ventilator while maintaining an artificial airway, complete extubation, meaning they're also taking out the artificial airway, and then symptom control of their pain, dyspnea, and anxiety. So your critical thinking challenge is you have a patient with end-stage heart failure undergoing a terminal weaning procedure of the ventilator. What might be some of the pharmacological management of distressing symptoms like anxiety, dyspnea, and pain that you may use to help accompany this ventilator withdrawal process? And what might be some of the interventions that you can use to assist patients and families through this process? Communication and conflict resolution. Effective communication provides consistent messages to the family, allows for ample time for the families to conference and express their feelings, and then identify the mutually agreed upon goals on the parts of the patient, the family, and the healthcare providers. This is one of the things that you want to use to help promote this communication, and it helps them work through the process. Part of what you are to do is to help allay fears of abandonment when the care shifts from curative to comfort. Facilitate continuity of care. Shift-to-shift report needs to happen. Facilitate that continuity of care between providers, between the units if a transfer occurs to a different level of care. So maintaining that continuity of care needs to be facilitated. Emotional and psychological care of the patient or family. The needs vary with an individual family. Assess what those needs are, not what they ought to be. Use non-judgmental assessment skills. Sometimes we need to broaden the definition of family. We need to provide spiritual counseling as desired by the patient or the family. We need to provide clear and accurate and understandable information. We need to reassure that the patient will not be suffering during the dying process. We must maintain cultural sensitivity, provide death with dignity. Generally, when you come to an end of life thing, you're going to have open family visitation. It helps to provide comfort to the patient and the family. And we typically try to do that in a private environment. We try to just put them in a private room, in a private area. Time and unit staffing can sometimes impact the delivery of optimal end-of-life care. A lot of hospitals have established bereavement programs, caregiver support programs. Patients and families need to be educated on the end-of-life issues, and also the healthcare providers need to be educated on this kind of information. The United States population has become increasingly diverse, and we do not see an end in sight. Cultural influences at the end of life vary by the group and by the region that they're in. It is very critical to understand the culture's response to stress and their beliefs on death and dying. It is critical for healthcare team members to understand the personal beliefs related to end-of-life care for that patient and family. Sometimes religious doctrine can affect the decision-making at the end of life. Caucasians often prefer less invasive and aggressive treatment options, where African Americans often prefer more invasive, more aggressive treatment options. So for conclusion on end of life, it is challenging. It can be rewarding. Nurses are in a prime position to support patients and families through a very difficult, very significant time. And the way you respond to this and how you deal with this with the patients and the family can be very impactful. I will tell you, if you've not dealt with your own personal feelings about death and dying, advance directives, and this type of thing, it will be even more difficult. I do recommend that you start thinking about this in advance, as it is something that you will have to be cognizant of, because it will happen. You will have to make that decision. You will have to come to terms with how you feel about it. Sooner, when it's less stressful, is the better. Okay, Chapter 6, the Nutritional Support Chapter, the last one for this group. It is an automatic assumption that all critically ill patients are assumed to be at a nutritional risk. Nutritional support is an important part of their overall plan of care. The anatomy and physiology review for the GI system is going to be very brief. You've done it in anatomy and physiology. You've done it again in med-surg, so we're going to do this really quickly. The utilization of nutrients is what we're talking about. Cells require carbohydrates, proteins, fats, water, electrolytes, vitamins, and trace elements for functionality. Nutrients are ingested orally by the mouth, which breaks down the food first with saliva. The stomach stores and mixes the food with the gastric secretions. It secretes an intrinsic factor for vitamin B12 absorption, and it secretes fluids high in sodium and potassium to help participate in digestion and absorption. Depending on where you grew up, you may hear this be called the duodenum or the duodenum. It is the first section of the small intestines. It is where the pancreas and the liver empty directly into the duodenum, and it is where minerals are absorbed. The jejunum is where glucose and water-soluble vitamins are absorbed, and then the ileum, or the distal section of the small intestines, is where protein is broken down and absorbed. Also, your fat-soluble vitamins are absorbed in the ileum area. The colon is where sodium and potassium is absorbed. Vitamin K is actually formed here. Water is reabsorbed in the colon, and the absorption of short-chain fatty acids happen in the colon. The pancreas secretes digestive enzymes. The liver has multiple functions, but one of those is that it will actually promote liquids that will help emulsify fats, and it is pushed to the gallbladder, and the gallbladder stores that and then assists in that emulsification of fats. A nutritional assessment provides a baseline subjective and objective data regarding the patient's nutritional status. It helps determine nutritional risk factors, identifies nutritional deficits, help establish nutritional needs, and then identify medical, psychosocial, and socioeconomic factors. So objective data in an ICU patient would be their medical history, any malabsorptive syndromes, What are the lab values? What do they mean? What's important? Intake and output, and daily weights. ICU patient subjective data is like their gag reflex, dysphagia, adequate dentation, oral mucosa. What is their hydration status? The overall goal is nutritional support consistent with metabolic needs and disease process while avoiding complications. Any patient who cannot meet needs orally for 3 days or more requires nutritional support. Typically, a registered dietitian will help make this nutritional care plan, if not do the nutritional care plan, but they need to determine what's the patient's calorie needs, protein and fluid needs, what are the intake targets, and what route of administration are we going to do it? Are we going to do it by IV, central line IV, peripheral IV? Are we going to do it by tube feeding? Are they going to eat and drink it? Are we going to do a gastric tube? Route of administration is kind of important. Measurable short and long-term goals need to be set. We're going to look at what kind of weight gain are you wanting, what kind of stability and lab values are you looking for. Those are going to help you reach your goals. Enteral nutrition, or an oral feeding delivered through the GI tract via a tube. This is the preferred method as it has a lower risk of infection and it is less expensive than some of the IV things. A small versus a large bore tube is used for delivery, and the gastric versus small bowel feeding. So is this a large tube in the stomach, or is it a small bore tube in the duodenum? Okay. Enteral formulas, there's some different kinds. There's a standard 1 calorie per milliliter, and it's on Chapter 6, Table 3 for you. It contains protein, fats, carbohydrates, vitamins, and trace elements. There are some specialized formulas like elemental, high protein, fiber enriched, and wound healing. Okay. There's even a few immune enhancing formulas which are on Table 6-1 for you. Short-term enteral tube feedings, you can use a large bore nasogastric tube in the stomach, nasoduodenal tube in the weighted tube feed to the first part of the small intestines, or even a nasojejunal, where it is fed down into the jejunum past the duodenum. Some long-term feedings, generally people will get a gastrostomy tube or a jejunostomy tube for long-term. There are 2 types of feeding schedules. There's a continuous, where it's generally those are the small bowel feedings, and it's on a pump and it runs 24/7. Intermittent, those are generally the large bore tubes, and the tube is ending in the stomach, and you will do a bolus feed or an intermittent feed. You need to make sure that you assess gastric residuals prior to feeding. How would you do that? How often do you want to do that? And why are we looking at that? What would be the differences between gastric and small bowel locations on how that would affect residuals and how you would do it? So let's make sure we talk about that in class. The guidelines for parenteral nutrition. Feeding is delivered via the bloodstream. And if it's a central line, it is hypertonic, and that's total peripheral nutrition. If it's a peripheral line, it's considered an isotonic mixture, because you can't put a hypertonic in there, and that's called PPN, or peripheral nutrition. Parenteral nutrition, peripheral parenteral. You need to monitor for any possible complications such as infection, electrolyte imbalances, fluid imbalances, hyper or hypoglycemia. Drug-nutrition interactions are very significant. You need to make sure that you're checking medications for compatibility with the specific enteral feeding. You need to flush before and after administration of any medications via that enteral tube. And your preference is that you get liquid medication formulations rather than crushing tablets and things like that, because that increases the risk of blocking that off. So you want to consult with your pharmacist if you have a feeding tube. So your nursing care needs to focus on assessing your patient's ability to obtain or use nutrients. If there's an infection, look for a malnutrition as the cause, possible cause. Be alert for food, nutrition, drug interactions. Assess for any recent changes in their health status. Maintain and monitor their weight daily. Assess their protein, energy, malnutrition, especially if they're elderly, and then make sure that you are interpreting laboratory findings cautiously. Monitoring for complications, you must be very careful, and you do not want to have a refeed syndrome issue. There's a risk for diabetes or glucose intolerance in some patients. And then monitor the liver function panels for those who are on parenteral support, because sometimes that can cause some liver issues. So preventing complications, you want to prevent an enteral tube obstruction. You want to prevent patient aspiration or improper tube placement, such as in the lung. Diarrhea, you want to prevent diarrhea, and the first thing you should consider is Clostridium difficile, because it is very contagious. Even the hand gel does not work. You must use soap and water, and your patient must be isolated if you suspect Clostridium difficile, and you isolate before you are sure or not. If it's not, then you can always discontinue the isolation, but if it is and you didn't isolate them, now you probably have somebody else on the unit who has C. diff. You need to monitor for dumping syndrome, hyperglycemia, or even electrolyte imbalances. Assess the patient's progress in meeting what the objectives for the feeding are about. It begins at the initiation of the therapy. Your stable patient needs to be assessed every week. If they're critically ill, they need to be assessed more often, typically every 2 to 3 days. Documentation is extremely important, and the registered dietitians are very good about doing their documentation and helping you have an understanding. Review any changes in their medications with the physician and the dietitian. If you have any questions, don't hesitate to ask. Bring them to the class. And this concludes your Introduction to Complex Care presentation.